Good afternoon, everyone. Thank you for joining us. My name is Lawrence Smith. I'm the Executive Vice President and Physician-in-Chief at Northwell Health and Dean of the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. I also chair the Roundtable on Health Literacy, a project of the National Academies of Science, Engineering, and Medicine. I would like to welcome you all to today's webinar, COVID-19 and Communities of Color, Implications for Health Literacy, which is hosted by the Roundtable. This webinar will explore best or successful health literacy strategies that health professionals, public officials, community organizations, and individuals can use to promote health equity in communities of color. A bit of background about the Roundtable on Health Literacy, which convened its first meeting in 2006. The Roundtable is made up of health literacy experts from fields including healthcare, pharma, community-based organizations, and more. We typically host 2 to 3 workshops per year, convening to share promising and best practices and cutting-edge research on and in health literacy around specific topics or issues. Most recently, the Roundtable has held workshops on integrating oral and primary care through health literacy practices, health literacy best practices in clinical research, and developing health literacy skills in youth. Later this summer, the Roundtable will convene a virtual workshop on addressing health misinformation using health literacy practices. Some housekeeping. This webinar is being recorded and will be archived at the Roundtable website, nationalacademies.org, Health Literacy RT. I would now like to introduce the moderator of this webinar. We are incredibly fortunate to have Dr. Ernestine Willis moderate this discussion. Dr. Willis recently retired from her tenure as a Kellner Professor of Medicine at the Medical College of Wisconsin. She is also past director and founder of the Center for the Advancement of Urban Children. Her interest spans from analyzing the impact of systems on children and adolescents, applied public policy, community-oriented programs, medical education, health assessments, and child advocacy. In addition to her work, she is affiliated with many local community organizations that promote the health and well-being of children and adolescents. I turn now to Dr. Willis, who will provide some opening remarks and introduce our speakers. Ernestine?
Thank you, Dr. Smith, for your kind introduction. And thank you to the Roundtable members and project staff for organizing this webinar on such an important topic today. Before we begin the panel, I would like to acknowledge that today is a day many in STEM and academia are pausing business as usual to transition to a lifelong commitment of action to eradicate racism. The call to shut down academia excludes those who are working to end the COVID-19 pandemic. We stand with the movement for Black Lives Matter and are pleased to host this webinar to you today. Given the current COVID pandemic and knowing that many of our Roundtable members are pivoting their usual health literacy work to focus on COVID-19, we felt it was urgent to organize a webinar highlighting some of that work to share with the public in addition to our usual workshop. We are grateful so many of you are here to join this conversation today. The COVID-19 pandemic is magnifying racial disparities and health inequities in the United States, which is more amplified by the coinciding nationwide public demonstration against police violence and for social and racial justice, which will not be addressed today in this webinar. We will address African Americans, Latinx, and Hispanic individuals are at higher risk for COVID-19 infection and death, in part due to the disproportionate representation in essential frontline jobs, lower wages, higher rates of poverty, and underlying health conditions, as well as less access to quality health care. When responding to this outbreak, health professionals, public officials, and community organizations can and should account for the fact that African Americans and Latinx communities are more likely to have lower levels of health literacy. Higher health literacy levels can increase the individual's ability to take action to manage their health and health care. However, health literacy encompasses skills beyond those of the individual to include the practice of health systems, clinicians, public health officials, community organization, and other entities. While health literacy strategies may not be able to address all underlying conditions that contribute to poor health, these strategies can help build trust between individuals, communities, and providers. Incorporating health literacy practices in prevention and care messages, communication channels, and clinician practice is only one of many strategies to address the risk of exposure to infections and the impact of COVID-19. With all of this in mind, these are the objectives for this webinar today. First, we'd like to identify what we currently know about health literacy and COVID-19 in San Francisco Latinx community, as well as the Southeastern District of Columbia African American community, based on Drs. Alicia Fernandez and Lisa Fitzpatrick local street outreach initiatives. Second, we want to share our observations on the implication for health literacy moving forward in response to the pandemic and potentially after it's managed. And last but not least, we'd like to discuss and acknowledge some of the limitations of health literacy strategies in addressing this pandemic. With that, let me introduce our two esteemed panelists. Our first speaker is Dr. Alicia Fernandez. She's the director of the Center for Latinx Excellence and professor of clinical medicine at the University of California, San Francisco, and an attending physician in the General Medical Clinic and the medical wards at San Francisco General Hospital. Her research primarily focuses on health and healthcare disparities, and she's particularly interested in vulnerable population, Latinx health, immigrant health, and language barriers. In addition to her research and clinical practice at San Francisco General Hospital, she does a great deal of mentoring students, residents, fellows, and faculty. Dr. Fernandez has received several honors and awards, including the Arnold P. Gold Professorship for Humanism in Medicine. Following Dr. Fernandez will be Dr. Lisa Fitzpatrick. She is the CEO and founder of Grapevine Health. Although her career has traveled transverse clinical medicine, research, and public health program implementation, she is most passionate about improving the nation's health literacy and demystifying health information. Her goal is to inspire greater and more effective disease prevention and health promotion action in communities by making practical and usable health information more accessible to ordinary citizens. Dr. Fitzpatrick's skills and experiences are diverse. She is a medical doctor who began her public health career in 1998 as a medical epidemiologist at the nation's premier public health agency, the Center for Disease Control and Prevention, as a member of the CDC's elite epidemic intelligence services. She recently served as the medical director for Washington D.C. Medicaid program. She's also a clinical professor at the School of Medicine and the Health Science and a professorial lecturer at the Milken Institute for Public Health at George Washington University. Dr. Fitzpatrick has a master's in public health from the University of California, Berkeley School of Public Health, and a master's in public administration from the Harvard Kennedy School of Government. There will be time for questions after this presentation. If you did not submit a question through your registration page, please submit your question in the chat box on this screen. We will filter them during that time and try to get to as many questions as possible. With that, let me turn it over to our first speaker on the panel today, Dr. Fernandez.
Thank you so much. Thank you so much, Dr. Willis. I really appreciate the kind introduction. Let me see if I can get this going. Now I've just made a mess, so, sorry. I had practiced this, but I didn't practice, I didn't do enough. Share screen, sharing my screen. Now coming back up to my slides. Sorry, people, that I need to talk to myself. That is a trick of low literate people like me. And here, I hope you can see my slides. Again, I'm delighted to be here. I'm going to go fairly quickly because I really want to get to people's questions. So let me start by saying the obvious, that as you all know, COVID-19, is affecting, do you still see my slides?
Alicia, could you share your screen?
Can you see my slides?
Yes, great, thanks.
Sorry. COVID-19, as you know, is affecting some communities more than others. You see the hard hit Northeast, you see the Navajo Nation, and you see other hotspots throughout the country. There is a great website now coming out of Emory that allows you to look at things on your county level. This has helped people, I think, realize some things. I'm highlighting Georgia, and here we see that in Georgia, counties that have a higher proportion of African Americans are also more likely to have a higher COVID mortality. In California, I'm sorry, this is data from New York, again showing death rate, and you see here much higher death rate among African Americans and Latinos in New York City. And here you see how that tracks very well. These are cases, not deaths, but you see how that tracks very well with poverty. Going quickly to California, in California, you should be able to see in terms of the number of cases, Latinos, 54% of the cases are Latinos, whereas Latinos only make up around 39% of the California population. But at the same time of the deaths, African Americans have a death rate that is almost twice their proportion in the population. So do Native Hawaiians and other Pacific Islanders, which in California is actually mainly Samoans, which have a death rate almost 3 times as much as their representation in the population. And these are all very, very troubling data. The Latino population skews young, and so that is why you don't see the excess death rate in among Latinos in California unless you look by age group. If you look by age group, and we're looking at ages 18 to 49, we see a death rate very out of proportion to the level in the population among both African Americans and Latinos. I bring this up because it is important to note that even within this, everything differs by location on the country. And this report out of the Chronicle compared New York City and San Francisco. New York City has about 10 times the population of San Francisco, yet it has about 100 times the number of cases and way, way, way excess deaths, because in New York City, as is known, the healthcare system was completely overwhelmed, whereas in San Francisco, not only did we have few cases, but a lot of, but because of that, a lot of excess healthcare capacity. I bring this up because I think it's important to recognize how the epidemic is affecting different regions and different localities of the country differently. I want to take you, however, to San Francisco data. This is a study available on the web, and a study conducted by some of my colleagues, Dr. Diane Havlier and Dr. Gabe Chamey here at UCSF, San Francisco General, but it was really a study done in collaboration with a lot of community members, many, many, many community members and many organizations. And what they did is that they looked within the Mission District, which is a historical Latino district in San Francisco. They took one census tract. And this is a census tract that has 4,000 adults, about 58% Latinos, and about 34% with a low household income of under 50,000. This is census data. It is a very dense, like most of San Francisco, it is a densely populated census tract. And what they did was conduct testing over 4 days by putting up tents in the parks in collaboration with community groups. Because of this, they were able to reach 55% of the total estimated population of the census tract and 57% of the households. This is truly remarkable population level data and represents an academic community partnership which has been extremely fruitful. Because of this, they were able to find that the PCR positive rate for COVID-19 was overall, was of the 3,000 community members tested, was about 2.1 overall. But in people who came to work in that census tract, it was about 6.1. And in people who lived in that census tract overall, it was about 1.4. So you can see that these are relative low prevalences compared to some of the places in the country. But let me show you what else they found. What they found was that it was the people who were positive were people who reported being unable to work from home. That people who worked from home, and highly disproportionately, people who were unable to work from home compared to the overall. 90% of people reported working outside, unable to work from home compared to 57% of the houses. Who else was positive? What they found was that it was disproportionately men. And then in this very, very mixed census tract, where 44% of those tested were Latinos, and 38% of those tested were white. What they found is that not a single white person tested positive, nor did the small number of African Americans, and that all of the people who tested positive were Latinos, except for a few, actually Filipinos, who also live in this neighborhood. This is glaring exposure of this excess risk. Moreover, people were poor. They were concentrated in the lower household income. And they tended to live in large houses compared to the rest of those tested. So we also analyzed the cases. We are the hospital for the mission at Zuckerberg San Francisco General. We analyzed our first 70 cases. 83% of those were Latinos, 64% were men. They skewed young with a median age of 47. And again, we see this high density housing status. About 30% were in essential occupations, and everyone else was a low wage worker. So in fact, our prototypical hospitalized patient is a middle-aged Latino man with diabetes and obesity, limited English proficiency. These were almost entirely monolingual Spanish speakers, a low-wage worker with congregate living situation. And to make the obvious point, this prototypical patient also has low health literacy and little education in Spanish. So now I'll turn now to talking about our work and what we've been doing. So first of all, I direct the UCSF Latinx Center of Excellence. These are some of our members, and we've been working, this is our second or third year of operation. We have an advisory board that includes people from the Department of Public Health, as well as workforce experts, and also, importantly, CBOs. Our faculty and staff are about 50% African American and 50% Latino. We decided to focus on the main pillars of a public health response: prevention, testing, contact tracing, and health policies. With prevention, clearly the most important aspect was a trustworthy information: stay-at-home policy, shelter-in-place policies, physical distancing, and use of masks. With testing, we needed to work with the San Francisco Department of Public Health to lower barriers to testing, in particular barriers of access, of cost, and of immigration fears. And I'm going to tell you a little bit about the contact tracing and the health policy work. So our first thing was to push out reliable public health information in Spanish as fast as possible. And we did this in 3 ways. One, we used media. We did a lot of work with television, with Univision and Telemundo. We did lots and lots of radio shows, interviews, and call-in shows. So that was a really important aspect. Second aspect is that we worked with community-based organizations because they are trusted intermediaries. Their own staff needed to have physicians to whom they could ask questions and get the answers that they needed so they could in turn perpetuate accurate, rapid information. And finally, we did direct Q&As with community members, both on the radio and on webinars. So we did 5 webinars with CBOs. We have done Facebook Live sessions where people get to ask and answer questions. Some of those have been on children and COVID. We did one that was very important on mental health and COVID that got a lot of attention. All of these are in Spanish, except for the webinars to the CBOs, which are in Spanish or in English, depending on the CBO's needs. We also created a street team, and our street team goes out to the food distribution lines, which very unfortunately are getting longer and longer, and we disseminate masks and disseminate health information. This allows us to answer questions directly from people and to address fears that individuals may have. Well, in this work, we have been joined by wonderful student volunteers from the UCSF professional schools. In all of our materials, we're using obviously plain language. And then we vet our own Spanish multiple times for country-specific idioms in other words, to avoid country-specific idioms and to focus on simplicity. We also focus on a low literacy format in which less is more. I don't need to tell people on this call that this is very difficult for academics. And consequently, when we do our webinars, we limit our speakers to 7 minutes so that community members and CBOs can ask questions. We also address the cost of testing, et cetera, which is free, and documentation, immigration fears, in every talk and on every handout. Finally, when we've worked on testing, we've really tried to put out good information about where to go. Now, San Francisco, like many places, struggled with testings, and testings were by appointment. The appointments at first were barriers because people had to call and make the appointment, but also because the city wanted to give people good care, and so they tried to ask questions about their medical health insurance in order to eligibilize them for Medi-Cal or for our city's own health program. Those were very intrusive questions. And by having members of our staff serve as secret shoppers, we were able to get that policy changed very rapidly. This is another role that academics and CBOs can play in advising DPHs. Contact tracing. Contact tracing is when someone calls up the patient and says, tell me everyone you've been in contact with starting 2 days before you became ill. I don't need to tell you that for many of our communities, this question automatically creates a sense of worry, uncertainty with what the authorities will do with the information, and trust and fear. And what instead we want is people to feel some sort of trust and some sort of comprehension of why people are asking and why it's important to give complete answers. My own research is on language barriers. And what I can say is that trust is much higher with language concordance and physicians. In other words, when the physician and the doctor speak the same language, it is easier to elicit, to create a trusting relationship. And that's been shown in multiple studies. Similarly, comprehension is much higher when the physician and the patient speak the same language, even when people are using professional interpreters. Finally, even some outcomes are better. My own work has shown that blood sugar control improves when people switch from a non-Spanish, when Latino patients with diabetes switch to a Spanish-speaking MD. And I have references on all of these at the end. So language concordance is a must, but also important is cultural concordance. The data on that are not as strong, but because we believe that, we have been working to stand up community health workers from the community-based organizations and training people to do contact tracing. All of this falls under, if you want a theoretical model, this falls under the collective impact model. And the collective impact model has 5 conditions, and these falls under these mutually reinforcing activities. Why do we do radio and television and at the same time send people out to the lines? It would seem to be the opposite strategic, and yet these become mutually reinforcing. Let me switch now to say that our first wave was not very bad in San Francisco in terms of morbidity and mortality. But the second wave, and nor was consequent the second wave of rehab, where we are seeing a lot of impact is on the wave of impact of care on chronic conditions. And then, of course, unfortunately, the fourth wave of mental health issues and psychic traumas. We are particularly concerned around these two in this area. Even to date, we have UCSF Health has been able to look at their data, and they find that in terms of visits prior to telemedicine in the blue and after telemedicine, we are seeing fewer appointments in older people, much fewer appointments in people who don't speak English, and then Medicare and Medicaid. Why is this? Because there's a digital divide, but there's also a question of digital literacy, so that it is very hard for people to download the Zoom and get the other things and do these manipulations that they need to do in order to set this up. I also point out that this causes that televisits put an even greater burden on people to do their own self-management and their own self-triage. They're the ones, instead of me being able to notice the rash, the shortness of breath, they are the ones who have to say these things and notice and think to bring it and have the empowerment to bring it. That is very difficult. Finally, in this polyglot city, the issues of language access are very severe. It's particularly difficult to integrate into telehealth. On top of the things that I've already told you about as contributing to health literacy is economic injury, and that is what we're struggling with right now. From the Pew, and I have mentioned the food lines, these are very long. We're now participating in these almost every day, and they're blocks and blocks and blocks long, and people are lining up for hours to get food. From the Pew research, you can see that job loss was higher among Hispanic and Blacks than among whites. And you can also see that in terms of the percent of people who said they do not have rainy day funds, almost 50% of whites, lots of poor white people out there, and yet almost 70% of Hispanics and Blacks. So again, lots of people really suffering the humanitarian crisis. Finally, we have been doing work on health policies, trying to get the city to put into place, because people are getting infected, because they're going outside, because they have to go to work, putting in place workplace protections. We have been calling for extension of the CARES Act sick leave to small and large corporations. So if you're a janitor in a hotel, you don't have necessarily sick leave protection. If you are a delivery person for a small restaurant, you don't have that. These are the people we're seeing getting sick. We believe that sick leave needs to be extended to people in undocumented and mixed status families. And the reason for that is quite simple. People need to be able to stay home, regardless of anyone's views on immigration. Isolation and quarantine are key aspects of pandemic control. And consequently, we have to make it possible for people to not have to go out to work. And they are not the financial reserves to allow that. And I have already spoken about diversification of the healthcare workforce. I hope people come back to me with questions. I think this is a key aspect. So in summary, COVID-19 has been a great revealer for many people who are not previously aware of healthcare disparities. But unfortunately, COVID-19 is also a great enforcer, as it is further deteriorating the social determinants of health, further pushing people into poverty. And I think of it at the same time as an opportunity to strengthen the public health system, strengthen the relationship of health systems to community-based organizations, really work on social policies that can help us take better care of those who are more vulnerable. And then as a physician at an academic medical center, I believe it has really revived the notion of professionalism, which I think is really key, and the importance of trust, which is also key. Let me stop here and turn to Dr. Fitzpatrick, and thank you very much.
Thank you, Dr. Fernandez, for that vital work in the Latinx community. Let me now turn it over to Dr. Fitzpatrick as our next presenter on her work as a street outreach initiative in the Washington, D.C. community. Dr. Fitzpatrick.
Hi, everybody. Thank you very much. I want to give a special thanks to Alexis for herding the cats and pulling this off. I'm really excited to speak to you today about what we've been doing in the community. I think Alicia gave you a very good overview, a lot of which is also appropriately relevant for what we're seeing in Washington, D.C. So I would like to take this conversation to the ground, which is where Grapevine Health works. And I'm excited to tell you about Grapevine Health. So for the next few minutes, we'll talk about what we've been up to during the pandemic and share some insights from the community. So in the short amount of time I have, I'm going to cover quite a bit and hope to answer your questions on in the areas where I haven't done the information justice. So I will cover at a very high level some concerning issues around COVID-19 in the district, talk a little bit about why this disparity exists, and then focus on the response, what we've done, and some of the insights from our activities, and then offer some recommendations. I started Grapevine Health because I believe no one should die of a preventable illness simply because they don't understand health information. So pre-pandemic, and even now, we focus on earning community trust, bridging health communication, exploring digital health solutions, and creating culturally appropriate communication specifically for Medicaid populations and underserved communities. And I have to acknowledge the Grapevine team. They are a very talented group of folks who are very committed to the work we're doing, especially during the pandemic, and I'm so proud of them. So what have we been doing and what have we been learning? First, I want to talk about this statistic that is most concerning to me. The statistics you heard from Alicia very much mirror what we're seeing in Washington, D.C. But of the 483 deaths from COVID, 75% of these deaths have been among our Black residents. And 34% of those are from nursing homes. I had a conversation with the city's medical examiner who provided this information. And as you can see with a quick calculation, nearly all of our death cases are among people who are over the age of 60. And our work, if you look by ward, Ward 7 and Ward 8 are what we call east of the Anacostia River. And our work has primarily focused in Ward 8, where you can see we have had the highest number of deaths. So among the activities we've conducted during the pandemic, we've been focusing on improving health literacy and addressing COVID misinformation. And this is just one of our activities. This Dr. Mitchell pictured here is the city's medical examiner. And we talked about the death disparities. And he believes what's driving these death disparities are linked to the things you see here on the slides, age, we already talked about that. Chronic health conditions, nearly all of the people who've died had some underlying chronic condition, but one of the most interesting things he told me, when we talked about symptoms, we wanted to educate people about the symptoms of COVID. He said, in the clinical record, some of the folks did not have the typical symptoms, and one person presented with chest pain and was having a heart attack and died of COVID. We also talked about distrust in public health guidance and the need for especially our youth and young adults to heed public health guidance, because Dr. Mitchell believes a lot of the cases he's seeing are from households that have youth that are out in the community and go back home to their elders. And then finally, something, the issue that's brought all of us here today, low health literacy, including misinformation, and I'll talk a bit about that in a second. And this is just to also highlight some of the other ways we've tried to conduct outreach during the pandemic. We have a Google number we've publicized specifically to allow people to ask questions about coronavirus, and have held some community sessions over Zoom to answer people's questions. I also want to highlight some of the local service organizations we've been working with, and this one in particular is Congress Heights Senior Wellness Center. I have a standing meeting with them every Tuesday to talk about the pandemic, coronavirus, or any other health concerns they have, and we have a great time. And I asked them for permission yesterday to show this screenshot. And you can see they're waving at you. They're a very lively bunch, very engaged, but mostly I want you to recognize that these are all seniors who are online. And we've also just launched a podcast. This is hot off the press, and the first episode is available. The purpose of this podcast, I decided to launch the podcast pre-pandemic, but now we're focusing specifically on pandemic-related issues. So this first interview that we published online is Miss Roney, and she's such a delightful person, and she has great stories to tell, including why she has decided to stay in, or why she decided to stay in her house for 90 days. So I won't tell you the answer. I will let you listen to the podcast so that you can hear from Ms. Roney. But the idea behind the podcast is to help improve health literacy by talking to experts and community members, because we don't spend enough time listening to community members. Grapevine Health also has a focus on digital literacy and digital health. And given the increased attention now focused on telemedicine and telehealth, we seized an opportunity to ask the community about their receptivity to telehealth and digital health tools. And the data collection is ongoing, so I'm not going to spend a lot of time here, but I want to highlight a few things I noticed when I looked at the data thus far. The 68% of the people who've responded, and the ages range from low 30s, and the oldest person is 81 who's participated in this survey so far. But 68% had some sort of televisit during the pandemic. 42% were undecided about continuing post-pandemic, which I found very interesting. But there's a question, a subsequent question about how did you like the visit, and would you like to continue with televisits? And only one person didn't like the televisit, and her comment was, "I'm having trouble using my computer." What people liked about it so far, we've learned that it's quick and it's convenient, which shouldn't come as a surprise. And when the pandemic is over, would you like to have video visits? I was a little discouraged to see that only one person said definitely, but we still have opportunities to convince people about the value of digital health. So what are we hearing from community with respect to health literacy? As Alicia alluded to, there's a lot of misinformation, and I'm sure many of you have run across this and are very well aware, but when we're on the ground talking to people, we do hear these things. We've had a lot of people asking about whether or not hot water prevents coronavirus infection, and I think a lot of this misinformation was circulated early in the epidemic before we had an opportunity to address the misinformation, and it became common knowledge in the community. You may have also heard about an early rumor that Black people may be immune to coronavirus infection. And unfortunately, that rumor did gain traction because we've had people asking us to verify that information as well. And we're very accustomed to hearing about conspiracy theories. the one we're confronted with a lot is about whether or not this virus is real. We talked to Dr. Mitchell, the medical examiner, about this during our discussion, and he tried to impress upon the public that this is very much real, and he saw the evidence in his pathology lab. And what did we hear about low health literacy and the pandemic? These are some of the most common questions we got. We have been collecting video footage, and I elected not to show it today, but it will be on the web shortly on YouTube. But so many people are confused about the symptoms of COVID. At least 2 people told us they didn't know the symptoms of COVID, which led me to inquire about where they're receiving their health information. And although people may access health information on the internet or on the television or on the radio, somehow we are not doing a great job communicating with all people about the symptoms of COVID. Lots of questions about whether or not there's a cure and if the cure is available but being withheld from people. Again, more conspiracy theories, mostly in an area where we also encounter a lot of distrust of the medical system. And then there's a lot of confusion about how coronavirus infection is different than the flu, and the need to explain to people about R naught or the infectivity or how much more efficiently this virus is spread. And then finally, if you listen to the news, listen to a lot of scientists nowadays, we're pinning a lot of our hopes on the vaccine. But I register this concern among the public, people who may be hesitant to take a vaccine, that we have work to do to educate people about the need for vaccination. And as I talked to one person a couple of weeks ago, she said, well, I never even get a flu shot. And I had to think about that because 1/3 of my patients when I was practicing refused flu shots for a variety of reasons. And so we need to think about how to approach these discussions and convince people of the need to consider vaccination should one become available. So what are some recommendations for those of you who are working in health systems or who are interested in improving health literacy? First, design communication for the audience. When we're on the street, we hear different terms than you might hear in the media. The best example is the term being used for COVID-19 or coronavirus. One is the Rona, and the other one is NC Rona. People also describe symptoms in different ways. A gentleman told us when we asked what are symptoms of COVID, he said hot temperature. So I think as we endorse symptom checkers and think about the AI-based tools that are being developed for COVID or that are even already out on the market, it's important to consider what language is being used as we build those tools and disseminate them to the public. And I've included this ad from the American Heart Association because I think it's a great example of how to design an impactful ad for a specific audience. We've also learned, and we knew this long before the pandemic, is the use of visuals can be really impactful to improve health literacy because it helps people understand the how and the why, 2 questions that are often neglected when we are practicing medicine or communicating health information. If we can help people understand what's going on, they're more likely to retain and eventually use the information. Just a reminder that technology can still be a resource I think the common perception is that in underserved communities, because of the digital divide and many people not having computers or desktops, laptops in the home, that we're unable to reach them with digital tools, and there's less of a need to design digital innovations for this community. But I disagree with that, because this picture, which was taken pre-pandemic, was at one of our outreach events, and we were collecting text message, we were collecting preferences for how people wanted to stay in touch with us digitally. And everyone we run into on the street almost has a phone of some sort, and it's a smartphone. So there are ways to reach people with technology, and we should not allow the arguments or the debate about the digital divide dissuade us from incorporating technology in our strategies to reach people with accurate health information. And don't forget, as I showed you, seniors are online too. So let's not buy into the stereotype that seniors do not like technology. My last recommendation is related to a community that we often don't think about. And I think our challenge is to provide support for people who can't easily practice prevention. Alicia mentioned people who can't stay at home, but even beyond that, what about people who don't have a home or who don't have consistent access to hygiene products? Water, for instance. This is the bottom left photograph is a photo I took in the community of a hand washing station, but it was out of soap. So I think we have to keep our less fortunate top of mind in situations such as the pandemic. And I've included some quotes here because I think they're very powerful, and these are from some of our partners. The first one, Miss Reeder, who's the CEO of Far Southeast Family and Strengthening Collaborative. I spoke to her the second day of the stay-home order, and I said, why do we always forget about the poor? And she said, we don't forget about the poor. We failed to plan for the poor. So the reminder here is to be holistic in our messaging and our strategies as we try to protect the public's health. So before closing, I want to, this is a photo I took this morning, by the way, on my walk. I decided to walk down by the White House. And I love this picture and thought I would share it with you. Before closing, I want to acknowledge the unprecedented time we're in. While it may be tough to have difficult conversations about race, bias, and issues we often shy away from, if we keep pushing through, the result will be more understanding and compassion, which I believe are foundational to addressing disparities. But I also want to recognize those who participated in the White Coats Black Lives demonstrations. I think it's a great first step, but I ask everyone who's taking a knee, whether doctors or administrators or C-suite leaders, to reflect upon why so many Black and brown people in America distrust health systems, and why some people like Ms. Roney would rather die quietly at home than be subjected to the mistreatment, judgment, and bias she might encounter in our health systems. So after you stand up from your demonstration, look in the mirror and ask yourself, how have I been part of the problem, and what will I do to make it better? And I certainly will. So I want to thank you for your attention. And again, a big shout out to the Grapevine Health team. And then finally, I'd like to thank all the sponsors and partners who stepped up during the pandemic to ensure we had the support we needed to do this really important work in the community. Thank you.
Thank you both for those outstanding presentations today and vital work that both of you are taking on in the streets. I would like to pose, though, as we start our discussion, a first question that I'd love to at least put forth before I look at the questions coming from the participants was, Dr. Fernandez, you talked about the different citizens and the partnerships, but how are you working to reach the undocumented citizens and identifying facilitators and barriers to ensure that that population is getting the testing and services that they need?
Yes, thank you so much for the question. We're working very closely with the undocumented communities, and we're doing that in two ways. One is we need to acknowledge that we have three coexisting pandemics: COVID-19, the pandemic of poverty now, and then lastly, at least for so many people, immigrants, the pandemic of fear. And so what we're doing is trying to do everything possible every time we talk to talk about what that the Immigration Naturalization Service has said, that they will not consider coronavirus testing in public charge proceedings. And we've made that statement over and over and are trying to get that out. We also explained that in San Francisco, no information will be shared with immigration authorities, and that's true actually throughout California. And so that people can name names and contact tracing without being worried that they're giving the name of someone at work and that they don't know whether they're documented or not and what's going to happen with them. But it takes a constant discussion on these points in order to make people feel more secure, and even then it's very hard.
Thank you for that response. Dr. Fitzpatrick, I want to know, because you have been working with trying to craft appropriate messages, how have any of the common messages used for COVID, especially those with CDC, been audience tested? And more specifically, I wanted to get into some of the terminology you talked about when it comes to how we use certain phrases, whether it's mass, diagnostic, antibiotics, some of those terminologies. How has that been tested in the specific population that you're looking at?
Well, we haven't conducted this like a research study. I think it's really important to collect data systematically to answer questions like that. However, in conversations with people, it's clear they're conflating terms. They don't understand a lot of the nuances around what we're talking about. And I think people do the best they can to take the information they're hearing and make sense of it. So the example I'll use is a gentleman who came up to our table to look at the organ model. And I said, do you know the symptoms of COVID? And he said, shortness of breath. And that's the only one he knew, actually, which was concerning. But that's why we were out there, to talk about the symptoms. And I said, well, do you know what organ in the body is associated with shortness of breath? And he said, oh, I think that's the lungs. And I said, well, do you know where the lungs are? And he pointed to the colon. And then we continued to have a discussion that revealed a lot of the nuance or the specifics of what we've been talking about with this pandemic. The testing is very confusing. We don't take the time to explain the difference between an antibody test and the utility of that versus the diagnostic test, which is PCR and so on. So I think we need to conduct the type of research you're talking about, but I think in this moment, the most important thing is to find ways to push information out and listen to where people are confused so that we can help address that.
Okay, thank you. I'm gonna follow up for a question for both of you, if you don't mind, and I'd love to hear both of you elaborate on this. What role does healthcare systems play in the messaging, public health messaging, versus the traditional public health department? And I'd love to hear both of you respond to that.
I think one of the things that's important for us has been to consult to the health department to make them more effective, and I talked about that. But I also think that the healthcare system has to do everything possible to lower barriers to care, which means having it be as easy and as trustworthy as possible. And sometimes that works, and sometimes it's really hard, and that's where alternative testing sites come in, and setting up testing sites in the community, which we're also doing in San Francisco. Before I want to be sure to let Dr. Fitzpatrick respond, but before I do, I wanted to say one more thing, and I'm sure Lisa would agree with me, which is it is also important to use non-written, beyond written materials and pictures. What we're started to do, and I forgot to mention, is use videos that we can text to people's phones and that they can watch again and again. So we're making videos on using masks, videos on, so you tested positive, video, oh, you tested negative, that explains what does it mean that you have a negative test? What does it mean if you have a positive test? And so on and so forth. And we're working on those in conjunction with community-based organizations and with the Department of Public Health, so as to make sure that we're all on board with the messaging, and so that it can be distributed throughout the city. We'll make those available on our website. They're not fancy. We'll make those available on our website if anybody else wants them throughout the country.
I have a lot to say on this, but I'll truncate my remarks. And yes, video critical. For those of you who don't know about Dr. Lisa on the Street, I invite you to check those out on YouTube, because we'll be using that a lot more as a mechanism to improve health literacy. But the issue, what's stressing me right now is understanding when you're on the street, you understand the problem at a different level than when you're inside the health institution. And what's become painfully clear to me over the last couple of months is we're leaving a lot of people behind. They're not being served by all the resources we have. We have a lot of resources in this city. We have one of the highest levels of insurance coverage. We have lots of primary care. We have an abundance of hospitals, but we ran into so many people who had questions about their health insurance. We ran into a woman who asked us if we could help her get health insurance. And it turns out she actually had health insurance, but she didn't know. And another gentleman who was recently released from jail was not connected to healthcare. And so all of these stories, I could go on and on about the need to connect people and find them where they are, but it's led me to pivot a little bit our mission away from the digital aspects and more to the feet on the street approach. And so now we'll be turning some attention to finding support for a street medicine program, so that we can meet people in the community and let them ask those questions, those things they're intimidated about, and won't go into a primary care clinic or into a hospital for a variety of reasons. And so if we meet them in the community, we can then build the trust needed to get them to take another action, like use a digital tool, like connect to primary care.
Okay. In the interest of time, and there's quite a few other questions that participants have put forth, can I just ask you to briefly just elaborate, Dr. Fernandez, on the cultural competency skills for the different populations? And please be brief, because I have to wrap up in a few minutes.
I think cultural competency is very important. I think it's very important not only for the Latino community, but I think it's very important to any community where there's issues of trust. Because cultural competency means having a really good understanding of what some of those issues may be. And trust is germane to everything we're doing.
Do you have anything you want to add, Dr. Fitzpatrick?
No, I think we're out of time, so I'm okay.
Okay. Well, let me just briefly summarize that that basically I got the message from all of you. It's essential to build trust within the population that you're trying to impact. Partnerships, and especially to remember all the other resources in the community for professionals, care professionals, to tap into those. The cultural fluidity of our institutions and relevance, it seemed to come up over and over again, especially specific to the audience. Don't forget to use the digital technology, because that population has more skills and proficiency with using that than we think. And please don't forget the high risk population, whether it's homeless, undocumented, and other populations who are impacted by poverty. I think that summarizes the beginning of the end of this webinar. And now I'll turn it back over to Dr. Smith.
Ernestine, thank you. And thanks again to all of our speakers, you, the moderator, the audience, for a wonderful discussion. Thanks also to the National Academy staff for facilitating this webinar. Please sign up for our roundtable listserv for updates about future webinars and workshops. Take care, and thank you to the audience.